Welcome to NetSmart Care Threads, a podcast where human services and post-acute leaders across the healthcare continuum come together to discuss industry trends, challenges, and opportunities. Listen as we uncover real stories about how to innovate and improve the quality of care for the communities we serve. Let's get into the show.
Welcome, everyone, to our discussion today. And thank you in advance for Jennifer and Hank for your participation and your expertise in the industries that you serve. So today we're going to have a lot of fun, have good conversation regarding integrated care and how we take those concepts to action and to drive those models across your organization. So we have a few goals, a few objectives that we want to achieve during our time together. So we're going to kind of dive deep in defining integrated care and doing it through the lens of Jennifer and Hank's organization, as well as from the viewpoints of NetSmart as well, and really focusing around the technology side. Also getting into how integrated care is being delivered. So whether that's delivered through partnerships or working with different health plans or operationalizing it inside of your organization, really going to get into some of those details to help you as you're thinking about your integrated care strategies. Also, we're going to look at some challenges and opportunities, so lessons learned around implementing integrated care models within organizations. And then also talking about some of the technology pieces. So what are the things that need to work from a data sharing perspective, from a virtual care perspective, and so forth. So taking a deeper dive in some of the tech spaces. So first, I'm really excited to have Jennifer Miller here with us from North Range to provide some context around integrated care. So Jennifer, do you mind introducing yourself, giving us a little bit of your background, as well as introduce us to North Range Behavioral Health?
Thank you for having me here today, AJ. So I'm Jennifer Miller. I'm the Program Director for North Range Behavioral Health's Integrated Care System. North Range is the Weld County Community Mental Health Center. We are a CCBHC. We are celebrating 50 years this year as an agency, so that's exciting. And we provide a very wide variety of behavioral health services within the community. Specifically within integrated care, we partner with our local community health clinic. And so we're co-located and embedded within 6 clinics here in the county and have staff at a couple of additional sites outside of those clinics as well. I've been in behavioral health for about 8 years, a little over. And my history has been mainly with crisis services. So I worked a number of years in our crisis response team and helped with our respite program within that team, and then also worked a number of years with our acute treatment unit, which is our inpatient psychiatric facility.
Perfect. Do you mind telling us a little bit about how you're defining integrated care through the lens of North Range Behavioral Health?
So we really recognize the interconnectedness and importance of looking at the whole health of a person. So really understanding that physical health, mental health, emotional health, spiritual well-being are all part of what people need to really reach their overall wellness goals. So within North Range, our integrated care model allows us to partner with our local physical health providers to really wrap services around people in the place that they're most comfortable. So we're able to really meet individuals where they want to be met and partner with their ongoing primary care physicians or health teams to make sure that we're providing holistic services and really addressing and identifying all of their needs as one cohesive treatment team.
And just a quick follow-up on that, from the holistic approach to care, I talked a little bit about social determinants of health in my opening. How are you incorporating social determinants of health as part of that interdisciplinary team?
So like I said, we work very closely with our providers. We're located in the same location. We really target some of those marginalized populations and help identify what are the barriers that they're experiencing to getting the treatment that they need. What are the things that we could help set up or help resource for them to make sure that they're able to meet all of their health goals, whether that's physical health or behavioral health, whether that's medication or ongoing therapy. And then how do we help them reduce those barriers? Is it helping set up transportation? Is it trying to provide childcare so they can attend groups? And we do a number of different things within clinics. So we really identify some of those populations that are more marginalized and provide specific services to those populations to make sure that their specific needs are being met.
Fantastic. Thank you, Jennifer. Appreciate that. Hank, welcome to the webinar. Do you mind introducing yourself, a little bit about your background, and introduce us to American Health Partners?
Yeah, happy to do it. And thanks for having me. So American Health Partners organization's been around for going on 35 years. It's taken the path of, in some ways, a traditional post-acute care organization. And then here more recently, I think have forged ahead into some of these integrated care value-based models in a really effective way. But in short, the organization owns and operates businesses in 7 different divisions, including nursing homes, home health and hospice, institutional pharmacy, psychiatric services in both the acute setting and outpatient, rehab, nurse practitioner services, all wrapped around our most recent addition to the American Health Partners family, American Health Plans, which is a Medicare Advantage plan that is provider-owned. And the driver of that, uniquely, the organization that's been around this long, providing services in the post-acute care space, about 6 years ago, myself and our executive team came into the organization, but came from a managed care background, and we're able to bring a lot of the components of the Medicare Advantage world into a provider organization in recognition that reimbursement risk was getting pushed down from payers to providers, whether you wanted it or not. And so saw the opportunity to bring some of that skill set into a provider organization and build out capabilities not only within our footprint and our 6 provider services divisions, but offer up a solution to providers and our brethren around the country. And we'll dive into that, I'm sure, through this conversation. But that's been the focus of our organization over the last 6 years, is to drive our organization away from fee-for-service and begin to bridge those different divisions through a unified clinical model, which is, as often is the case, reliant and dependent on a unified reimbursement structure. And my role within that as the development officer is to help develop those opportunities for the organization, partnerships with other organizations in our space and parallel to us, and actually rebranded to American Health Partners very intentionally 6 years ago for that purpose. We're very focused on joint venture relationships with other providers, not just operating within the continuum within American Health.
Fantastic. Thank you, Hank. And you talked a little bit around kind of what integrated care means from your perspective as you're moving from the fee-for-service model and bridging into value-based care. But is there anything else you would add from other aspects of the integrated care through the lens of American Health Partners?
Yeah, I think in short, the company did a good job of establishing businesses across the continuum, but the mechanism to link those and knock down the silo, even when they're underneath the same parent organization, is difficult. You're dependent on external organizations, Medicare Advantage plans, or Medicare itself and others to allow for that clinical model of care linkage, to allow for that unified reimbursement. And so for us, the model of care includes the reimbursement model because those incentives are so important. And so for us to layer in a payment mechanism that allowed us to overlay the different divisions and take true ownership of our residents and our patients' clinical story required us to take ownership of the financial components of that as well and not be dependent on third parties to that end. And so that's where we've set out to do and have been able to integrate not only our different divisions, but also integrate our provider partners around the country. And as you think about some of these themes, scale, resources, align incentives are so important. And that's a big part of what our story has been over the last 6 years.
Fantastic. That is great, Hank. And I think this is going to be the model that you are deploying out and executing on is going to lend well to this conversation, Phil. So thank you very much. And now we'll kind of get into the meat of it a little bit here. So Jennifer, I'll start with you. So when you think about, we talked about how healthcare delivery is shifted into more of the on-demand or open access and utilizing tools like telehealth as an example. Can you talk about how North Range Behavioral Health is working within the concept of meeting individuals where they are? And what does that mean for you? And how are you putting people and processes in place in order to best serve individuals, knowing that a one size does not fit all for everyone?
COVID really brought that to light, right? It had to be that quick shift into how do we get people the services they need and in a way that's still meaningful for them. So as an agency, we really, dove into that and really said, how do we reach people? So we use kind of a combination at this point. Telehealth is certainly something that is readily available throughout our agency and can meet the needs of some individuals. We still offer in-person sessions or services as well. We know some people prefer to be in that room with you and be meeting you face to face. Some groups and such are hybrid, so it really allows people to choose. Do you want to come in person, or do you want to kind of Zoom in, do telehealth, be joining us from home? And we recognized pretty quickly that within our community, we still had this population of folks that maybe didn't want to be in person, but also maybe didn't have the resources to be able to join via telehealth. So we also offer the resource for people who maybe don't have a computer or a phone readily available to come into the office, but still be able to join via telehealth from another room so that we're really meeting folks where they're at. The other piece is just having staff available in the integrated care model in particular, wherever the person is going to be most comfortable.
Excellent. And when you think about, implementing that model, that co-location model, what are some considerations that organizations need to think about from a process perspective, or how you actually, from a clinical perspective, implementing a behavioral health, physical health integrated model?
So fortunately, I was very lucky to inherit this beautiful system that was already built between our partnership, right? We've been doing this since about 2007. So I think we've worked through some of those strategies along the way. But really, I think it comes down to having that dedicated goal of serving the community, and really from leadership down, being dedicated to making it work and being dedicated to serving the community as one versus as two separate entities. The beautiful thing in the partnership that we have developed over the years is that dedication and loyalty between the two agencies has been so strong that there's really a commitment to making it work and to continue making it work. We recognize as a behavioral health care agency that we don't want to be a medical provider. We don't want to have to hire medical teams. We don't want to have to train. And our partners recognize that as well. They don't want to be behavioral health providers. They're medical providers. That's what they want to do. So really leaning on each other's strengths and being determined to really be one team and have that same goal and have that same purpose has been the biggest thing that I think has been our success within this program. And just working through things as they come up, staying in communication, and then transparency, I think, is the other thing, right? Certainly, within behavioral health care, there is a high level of confidentiality that we must maintain for our clients. But having some level of transparency between the two teams has been instrumental to our success. So within our partnership, our staff have access to the system, the medical records for the clinic, so they can see the medical records of anyone that's coming through, and there's obviously a release of information for that. But that allows us to really communicate freely with providers in that system so that we can document what we need to in ours, but we're able to have the whole communication picture within their system. And I think that's been an instrumental part of our success as well.
That's great. And that kind of moves into the technology piece a little bit. And Hank, as you talked a little bit about American Health Partners and the move into value-based care and the partnerships that you are creating in the ecosystem, from physicians to hospitals, even to the health plans themselves, technology plays a role. And, when you think about being able to access and share data to help improve care coordination. So kind of from your perspective, how does technology play a role when you're thinking about even in your in the context of the Medicare Advantage plan and the integrated care models, where you're trying to ultimately reduce risk, unnecessary hospitalizations, and improve quality and even length of stay. How does technology play a role when you're having these conversations and forging these partnerships in the community?
Yeah, so one of the real value propositions of provider-owned Medicare Advantage plans, which is what we are, and oftentimes that gets lost actually in the process, and there's so much work going into it, and you're boots on the ground, that sometimes we have to pause and say, we are the Medicare Advantage plan here. And what does that really mean? And as a Medicare Advantage plan, one of the most complicated positions in the healthcare ecosystem, because you're sitting in between CMS, the resident member, and the providers, both your provider partners and affiliated providers, but also the network of providers that are required to own and operate a Medicare Advantage plan, and then the family members associated with that member. So you're at that pivot point, and obviously that flow of information is critical, and just the blocking and tackling associated with all those different data components and technology components is critical to being successful, compliant. When you're a Medicare Advantage plan, CMS use you as they have outsourced this beneficiary to you, and so they're watching you closely and holding you to high levels of standards associated with that relationship. But the whole reason we're taking that step is that we're confident we can better manage the care of our patients and residents as the MA plan than a more traditional large MA plan could, given our intimate relationship with those patients and residents. And so for us, and I think this has proven to be the case on things like telemedicine and others, you don't start with the technology and then build your workflow around it. We're very intentional about touching our members and residents, being there at the bedside, having an intimate relationship through our staff in the field, having that intensive model of care focused on additional clinical resources, proactive clinical resources, and all those pieces. If you do that, the technology value proposition becomes obvious. I think where you can get into the challenge is when you try to build workflows around basically a solution in search of a problem. So we start with basic blocking and tackling, good clinicians providing good proactive care, and having the financial resources available to deploy those resources. And from there, you're able to identify ways to improve and identify opportunities from a clinical perspective. And we talk a lot of times about, as the MA plan, you have more data than you could ever ask for. As a provider, you're always begging for data. But as the MA plan, you have it, and all the claims are running through you. And so it becomes a question of how do you digest that and make it actionable and boil it down to really focused tasks. So at the end of the day, we pride ourselves on being boots on the ground, next to the patient, touching them, knowing what their needs are, knowing their dynamics. Buzz terms like social determinants of health. Jennifer, I'm sure your organization's known about those things forever. It's just been a question of who's paying for it. Do I have the resources to affect that? And as a provider on an MA plan, you get to make those determinations. And that's been the real value prop, and then to apply the technology resources around that.
Yeah, I agree. I think, looking at the clinical models, the engagement models first, and then how does technology come in to support those? I 100% agree that technology needs to be an enabler of those models, because that's the value that you bring not only to your residents, but also to the rest of the stakeholders. So maybe a follow-up question is, Hank, is, how do you think about building partnerships? Because this is obviously American Health Partners in your provider-led managed care plan. How do you think about partnerships on the community, hospitals, physician networks, and go about forging those?
Yeah, the concept on paper of provider and Medicare Advantage plan sounds obvious. Well, of course, why not? Who's better positioned to do this? But there's a tremendous amount of infrastructure required to be an MA plan. There's meaningful capital, and the number one inhibitor is scale. And so even for us, we have relatively good scale in our local region from a nursing home standpoint, home health and others, but we couldn't justify developing a Medicare Advantage plan on our own, given the infrastructure requirements associated with that. Just wasn't enough membership. And so even in our own market, we quote unquote kind of reached across the aisle, so to speak, and folks that we've competed with for years to develop joint venture relationships around this product. If you think about who we're targeting, our specific product is institutional special needs plan typically, and that's a long-term care resident, likely adult eligible, living in a nursing home, and they have very specific needs. And for us to come together with the other providers in our community to develop this plan allows all of us to provide additional clinical resources and more proactive care and integrated care to these folks that otherwise wouldn't be available. And so we took that model and in each state went and found the high quality, well-respected, typically locally managed and locally owned operators in those states, and created joint ventures where we could bring capital and infrastructure and capability and experience on the Medicare Advantage side. And they could do what they do really well, which is provide great care to the residents. But they now have a seat at the table on terms of how that model of care is structured. They have a significant upside on the outcomes, and we can come together and create scale through joint venture and syndication of other providers. And so in any given market, we'll have 2, 3, 4, even 5 providers that have invested real capital alongside us to develop these plans. That aligns incentives and creates a lot of sharing of information and best practices, and nobody feels like they're on an island. We're a provider too, so we can point back to the work we're doing in our home market, in our facilities, et cetera. So it's worked out well, but I think Jennifer said it right. It's a lot of conviction. It's a big step. It's a significant shift away from some of the fee-for-service siloed models of the past. And the vehicle's there to do it. That's the key. It works. The model works, but it doesn't mean it's not a big leap for any organization to take that step. And given the last few years and the challenges we all face, the advantages are obvious clinically, but getting there isn't nothing. You got to put a lot of time, effort, and conviction behind it.
Yeah, that makes a lot of sense. And that I think the key piece that you just touched on was the best practices and visibility to the outcomes, and looking at how do I impact outcomes before the reporting period ends. So having those data insights, identifying gaps in care, or even closing them before they even become a gap. And I think, Jennifer, from kind of your perspective, when you talk about your partnerships, we talked about with the primary care side, how do you think about, and talking about data, so having data available for both on the behavioral health and on the physical health side. So how are you thinking about solving for, data sharing, access to information, so that information is readily available at the point of service, whether they're engaging through the behavioral health front door or from the primary care front door?
So we currently use both systems, like I mentioned. So all of our data is readily available within our primary care health record system. They're able to pull all the data they need from their system, which is readily accessible anytime we need it. But we also want to capture that data for our agency for the behavioral health side. So we also reference that in our behavioral health side and bill out of that system. And then we can pull data to reflect services from our own system as well. So that's the process that we currently use. Again, the beautiful thing about our partnership is that we really talk to each other so frequently that pulling the data is very seamless. Whether we pull from one side or the other, we're able to access that data really instantaneously when we need it through our electronic medical records and reports. So that's been a beautiful way to track data and to make sure we're aligning things where they need to be, making sure people are getting the right services, making sure we're following up on maybe what they're seeing in clinic. And so that transparency between the systems has been a really nice way to support clients and support the community needs overall.
Yeah, it's interesting as we look at, the role that technology will play in that. You talked about your community partnerships. So working with schools, even community centers, libraries, even law enforcement around how do we create a wider front door for individuals to come into care. And we've been seeing a lot of clients and organizations utilizing technologies like telehealth, like consumer engagement platforms to make that door as wide open as possible, but also to have a streamlined process of how an organization can help manage those inquiries or access for individuals into care and services. And then looking at how to, one, leverage the technology to get them into care, but not once they're in care, how do we continue to wrap our arms around and have a finger on the pulse of those individuals in between the clinical services? So things like telehealth is one, but also looking at kind of health status monitoring. How do we drive assessments out to individuals to see how they're doing? And then based on how their responses are, then drives a very specific target intervention. So I think that the solution is complex, but a piece of that is around technology. And even to Hank's point, how do we leverage technology in order to enable our staff, our teams, and our clinical models, which I think is a really important part, one of the pieces to the puzzle that we're looking to solve for. So, so kind of moving into you, Hank, if Jennifer was talking about some of those different kind of provider models when looking at kind of the behavioral health aspect. So when you're out and you're looking at kind of, you mentioned the iSNP, there's also the hospital in the home, or even skilled services in the home. How do you think about meeting a need or a demand and putting together a model of a clinical approach model to address some of these different types of services as the industry is shifting even to more care in the home, as an example?
Yeah. A big part of where we build and where we're headed is kind of a tiered approach, where starting with provider-owned risk program, Medicare Advantage program in a institutional setting is a good place to start. You have maximum clinical impact and control. And as you expand beyond those four walls, the ability to drive that model of care becomes more challenging, but there's obviously a lot of opportunity as well. And so we're really thoughtful about what makes a provider-owned MA plan successful. What is the trade-off to significant scale is intimacy. And so we want to make sure that our providers that are partnered with, these are organizations that they know what they need to do. They know what resources should be deployed and when and how. They just never have had the mechanism to do that in the past. If you had aspirations to expand beyond, if you're a nursing home provider, for example, and you have aspirations to expand beyond the facility, where do you start? Even simple things like inside the nursing home, old, antiquated fee-for-service reimbursement structures just steer things in the wrong direction oftentimes. And so we talk about reimbursement models and controlling the Medicare premium from a clinical standpoint as much as a financial standpoint, because you can't redeploy resources unless you control the model of care and the flow of funds associated with that model of care. And so the best laid plans have oftentimes ended at the doorstep of a large MA plan, where you come in and say, I got this great story. We'd love to provide care in a certain way. Will you all contract with us accordingly? And the large MA plan, just because they're large and they have other things and their mechanisms to create value, fall more in line with contract negotiations and utilization management, not proactive model of care and investing at the bedside and investing alongside providers. They don't get funded, is the short version of it. And so when we look at opportunities in the facility to expand beyond the facility into the community, we're looking at it from a standpoint of, we don't want to get away from that intimate relationship with our members. We describe it as our members are our patients and our patients are our members. So that's one. And then two, can we work within the realities of owning the Medicare premium and reinvest those dollars away from traditional fee-for-service mechanisms? So instead of spending 55-60% of the Medicare premium dollar on hospitalizations, what if we invested in nurse practitioners at the bedside? And that financial return is there alongside with the obvious clinical return. So that's how, when we're looking at new models, new sites of care, our model of care is a capital M, capital C, submitted to CMS, scored by NCQA. It's a intensive process, but there are enough dollars there to have dramatic impact on clinical outcomes if the provider is actually providing the care to deploy those resources.
And what are some of if you can help kind of paint the picture of, how the reimbursement model works, how do quality measures, you kind of talked about NCQA, how do quality measures tie in to the model? And then maybe a double click down, how do you then ensure or drive clinical care to hit those quality measures?
Yeah, the beauty of the model of care is the quality and clinical outcomes align so well with the financial outcomes. A bad clinical event is hospitalization. A bad financial event is hospitalization. So, and there's obviously other process out measures behind that both as a plan and as a provider, you've got to be checking those boxes as well. But all those things become obvious inside a proactive model of care when you're taking the financial risk and deploying the clinical resources accordingly. So folks are going to get their screenings. They're going to have their high touch. They're going to have their coordinated transitions of care because we all have the incentive to do that. And the model of care is structured accordingly. They're obviously, you can find bad apples anywhere, but providers aren't inherently bad at those things. They're not aligned with their reimbursement programs. And so those concepts emerge out of trying to fit a quality program inside a fee-for-service world. When you replace that fee-for-service world with full ownership of the Medicare premium, then those things become obvious mechanisms along the path of taking true accountability for our members and our residents' care. And so we're tracking all those things. We're making sure that our care management team is in the know, and we're backfilling those. But those pieces are there. That they happen. Your medication management, all those things are all part of the model of care because the provider now owns that story, and we know what needs to happen. Are we perfect? No, but we're a long ways from that fee-for-service model where we're trying to balance what we know we should be doing with how we can be sustainable as an organization. This does that a lot better.
No, that's great. I think that the measurement system is really important. And Jennifer, thinking about, obviously with CCBHC, we have pretty defined measures, but how does North Range measure success? So how do you determine is our integrated care model working well? What are some of those success factors that you point to?
Yeah, I think, the biggest one obviously being hopefully we get someone through the level of care and they don't need us anymore, right? Our idea is to kind of work ourselves out of a job by meeting the needs of the community. And certainly there's data for days. I think a big part of it is engagement. Are we engaging the folks when they need to be? Hospitalizations plays into that. Are we able to keep people out of the hospital? Termination rates, are people successfully completing their treatment with us and moving on to bigger and better things in the world? So there's a number of, things that we look at agency-wide within integrated care specifically. We really are looking at providing kind of those short solution-based kind of services for folks. So are we seeing them back in clinic with their providers with similar symptoms within the next 6 months, year, whatever is going on? Are we able to help them manage to stay out of the hospital? Are we able to get them connected to potentially, if they're experiencing substance use problems, with our medication-assisted therapy program? And are they being successful in being able to manage their symptoms through that program? So really it is that client-centered approach of, are we seeing progress in our population and the folks that we're working with, and are we getting them to the place that they no longer need our services? I would say that that's probably the biggest thing we look at, and are we being successful in meeting the needs of our clients?
And that's great. And I think about how does an organization like North Range, how do you keep the providers in sync as far as those goals are concerned? So I would imagine when you're looking at the impacts of hospitalization or rehospitalization, there's a number of different factors that could be driving that. Could it be medication adherence? It could be that a social need of the person wasn't met. It could be something on the physical health side. Maybe the social need wasn't met, so they didn't take their diabetes medication, which then drove them to the hospital. So I guess when you're thinking about different teams that maybe are part of North Range, but then also part of your partnership. So how do you kind of have that shared approach to driving those optimal outcomes? I guess more of the collaboration. How are you collaborating with those partners in that vein?
Yeah, I think that comes down to communication, right? And being on the same page. And so for us, it's vitally important that we are communicating with those providers. If we're seeing someone whose, symptoms are becoming more transparent, can we get them in with the doc and talk about would a medication be appropriate to help them? If they're seeing that some of those social factors are playing a role and someone's maybe struggling with increased stress, increased depression, increased anxiety, can they connect them with us quickly? And so I think it's that instant ability to connect about clients while they're in the room, right? They can have a patient in the room who's discussing life stressors that are really taking a toll on them. Rather than having to make that referral, they can just call and we can come right into the room and get them engaged into those services immediately so that we can start making that impact and hopefully then avoid that hospitalization. And then I think it's collaboration within our agency. If we know someone's struggling and we're seeing them in our integrated care program in clinic, giving that heads up to our crisis team and saying, hey, this person's not doing well. You may see them. We may send them over to you. What would be helpful for that person to support them? And just really working as one collaborative entity, if you will, to make sure that we're communicating about those needs and getting them the services and support they need as quickly and efficiently as possible to help support avoiding that hospitalization or to help support that continued growth and progress in their care and treatment.
No, that's fantastic. I think communication and collaboration is key. I think a piece of that is having good data, and how are we sharing data and sharing it more in the context of seamlessly, and then having it available at the point of service. I think that's a big piece, and Hank talked about that as well, as far as how are we helping drive the clinical standard forward. And it gets a little more complicated when there are relationships outside the four walls. And I think that from a data sharing perspective, that's one of the key pieces. And then a good clinical practice and a bridge between different care settings is important as well. So kind of as we come in a little bit, I want to ask each of you. Jennifer, I'll talk to you first. If you could put kind of your crystal ball out there, where do you see integrated care going? So as North Range is thinking about planning into the future, what does that look like from your perspective, from an integrated care model moving out into the 1 to 3 to 5 year perspective?
I think for us, at least here, integrated care will continue to grow. As the needs of the community grow, as the needs of our partners grow, we will continue to strive to meet those needs in any way that we can. So I think it'll continue to grow and it'll continue to enhance, as we're identifying, new things we can do to support the populations or new things we can do to support the community. We will continue to expand to meet those needs as much as possible. I think we'll offer whatever services are helpful. We'll continue to build partnerships and collaboration. And I think it really will just continue to flourish and to develop not only our partnership, but our ability to serve our community.
No, that's fantastic. And, and a similar thought from you, Hank, on kind of where you're seeing the market going from these different models of care that we've talked about, and how American Health Partners positioning themselves into the future.
Yeah, from where I sit, a lot of everyone knows the push to value-based care. One thing we stress is the concept of risk. We all have risk today as fee-for-service providers. It presents this idea that we don't have risk today. There's a tremendous amount of risk: collections, bad debt, utilization management, prior authorizations, ADRs, et cetera, et cetera. So this concept of moving down the path, in some ways, there's a great quote that capitation is freeing. And I think providers are going to increasingly seek that capitation. They're going to increasingly seek ownership of that premium dollar. We believe that Medicare Advantage is going to be the program that wins long term. There's going to be a lot of iterations on the Medicare fee-for-service side. You see that even just within the ACO, direct contracting, now REACH ACO models. Those are all moving in that direction as the Medicare Advantage world continues to expand. And so as a provider who has increasingly had experiences out there, primary care providers and the like, are sitting there saying, I've been in ACO for 4 or 5 years. It keeps shifting. I don't control the data. I keep getting ratcheted down. I know what I need to do. How do I actually take full ownership of this situation? And we think the provider-owned Medicare Advantage world is going to continue to expand. Folks are going to be creative about solving for the question of scale through syndication and joint ventures and mergers and the like. And then on the backside of that, what happens? Organizations like Jennifer's become increasingly valuable. It's less about having that surgeon and more about having that services that can control and care for these folks in the ways that need to be cared for, that maybe in the past weren't the focus of a fee-for-service world, but will become really incredibly valuable to have integrated into your model of care when you own that Medicare Advantage premium. And so that's where we see the world going. Providers trying to move up that proverbial food chain and find the services beyond what they offer to ensure that they're executing on that model of care.
That's great. I mean, it paints a really clear picture, both of you, around how organizations can play offense and help chart their own path forward and looking for opportunities to differentiate the fantastic clinical service offering that organizations have and how to get a bigger piece of the pie. And there's a lot of considerations, as both you both have shared, from a clinical, from a partnership, from taking on that risk, as you talked about, whether you realize you already are or not. But then there's also the technology component as well. And that's where kind of we see our role to helping that and looking at it from, some of the concepts both of you shared around, how do I ensure that data is being seamlessly shared across the different organizations that are going to impact the outcomes. Whether I'm directly delivering those services or through my partner, I need to make sure that the clinical information is available inside of a workflow. Also, we talked about how do we streamline those referral sources so that we make it really easy for a referral source to send us individuals to enter into our care, and then how are we reciprocating that information back to those sources and showing the outcomes in order to kind of stay in that narrow network mindset. And then also we touched on the virtual care and how does that play into account both on direct service delivery, but also in looking at how do I expand my services out to other partners and doing it in a way that is seamless for the partner as well as for the individual, and creating that digital footprint in the community. So when we think about the word scale a couple of times, how do I leverage virtual care as a way for me to scale my services out in the community? So taking us in for a landing, I really want to thank both Jennifer and Hank for your time today, for the great conversation and insight. I think it gave a really nice perspective and balance on different sides of healthcare and how they come together in order to provide the highest quality of care for the individual.
At NetSmart, we understand the challenges facing provider organizations. Our team will help you navigate changing value-based care models with solutions and services that make person-centered care a reality. We'll equip you with technology and services that provide holistic, real-time views of care histories that inform better decision-making and better outcomes. Visit us today at ntst.com. NetSmart, serving you so you can serve others. Thanks for listening to the NetSmart Care Threads podcast. Through collaboration and conversation, we can work together to make healthcare more connected than ever before and better support the communities we serve. To ensure you never miss an episode, please subscribe to the show in your favorite podcast player. If you use Apple Podcasts, we'd love for you to give us a quick rating for the show. Just tap the number of stars that you think the podcast deserves. Until next time.